Dr. Deepak Das, and I am a internal medicine doctor and a sleep doctor. And I've done my residency in India from Patna Medical College, and also I did my residency from UMDNJ in New Jersey, and then did my fellowship in sleep medicine from Dartmouth Medical School in Lebanon, in New Hampshire. And I did my specialty in sleep is pediatric and adult sleep medicine. And I've been doing that for like 15 years right now. I'm also board certified in internal medicine and sleep medicine with the fellowship in sleep medicine. Now, I also am a founder of a telemedicine app called Urgidoctor. This was intended to make life easy for the patients and also for the physicians to see each other in odd times and during the office hours and also in odd times to discuss their results, management of the diseases for urgent care needs, and also for connecting people who are dependent on the primary providers. So like somebody in the nursing home or somebody is in an assisted living, or somebody kids is studying outside the state, they would be able to join it and be a part of their healthcare needs. And today I'm trying to talk about insomnia, giving this example, a couple of diseases that can be managed and also assessed by the telemedicine app and how this can be useful. Having said that, I just want to know how many people up till now who have joined us are from the medical background, and they can put in the chat section maybe. And how many are non-medicals? I think I can see from here, I think Charlie and Braj and Braj is non-medical, and Anukul and Mansi Verma, medical. Okay, good. Very good. So I'm going to give like a half an hour presentation, and if anybody has a question regarding the disease itself, please put in the Q&A section. And towards the end of my talk, I can put the website for the beta testing for the Urgidoctor. If anybody is interested, they can fill the form and they can be a part of it. Also, if anybody wants a evaluation for insomnia through the telemedicine app, the first 20 attendees, if they're interested, they can fill the form, put their email addresses, and I can provide them with the free consultation through the app. That will be done in July because we are doing the final testing of the application right now. Having said that, let's start the presentation. So today I'm talking about insomnia and understand what insomnia is and this will go with the diagnosis, assessment, epidemiology, medications, and the most common conservative measures that can improve the disease. So by definition, if anybody has difficulty initiating or maintaining sleep, it's called insomnia. If it's more than 20 minutes to fall asleep for kids and more than 30 minutes to fall asleep or maintain sleep after waking up at night for at least 3 times a week is defined as insomnia. There are 2 kinds of insomnia, acute or short-term insomnia, and chronic and long-term insomnia. By definition, if anybody has these symptoms for less than 1 month of onset, this is called short-term insomnia. More than 3 months, it is long-term insomnia. This is more prevalent in older age group and also in female. Mostly in female, it is common because their sleep is relatively lighter compared to male because of estrogens. And also when they become mothers, they have a habit of waking up frequently at night. And when the kids grow up, it becomes a habit, and they continue waking up at night and have difficulty falling back to sleep. In older age, there's also something called circadian rhythm disorder, in which the clock in the brain is disturbed, and that can also mimic as insomnia. And we'll talk a little bit more about as the time goes by. The thing that masquerades as insomnia is called delayed sleep phase syndrome and advanced sleep phase syndrome. Let me tell you what it is. In delayed sleep phase syndrome, the clock in the brain, which is mostly present behind the pituitary gland, is called SCN, suprachiasmatic nucleus. The clock is moved forward. So what happens is that instead of going to bed early and waking up early, the patient goes to bed later and wakes up later in the daytime. That can also mimic as insomnia. Very common in people who are in adults and younger age groups. So maybe from 12 to maybe 21. I see a lot of patients in college or high school group who have delayed sleep phase syndrome. It's also called DSP, as we call it. The other thing is called advanced sleep phase syndrome, in which people tend to sleep early and wake up early. Very common in older people, and this can also masquerade as insomnia. The most common cause of short-term insomnias are any recent stressors like childbirth, job change, divorce, marriages, even time zone changes can also cause short-term insomnia. Certain medication can also cause insomnia. Most of them are beta blockers, they interfere with the sleep-wake cycle. Narcotics can make it, in some people it make you sleepy, in other people it can make you more awake. Recent surgery, pain, accidents, anything that has a onset on the sleep-wake cycle can cause short-term insomnia. For chronic insomnias, the most common cause of chronic insomnia, either it is cause or effect, we do not know, but is anxiety or depression. So long-term anxiety, long-term depression can cause insomnia. Very common. People mostly see in depression more than anxiety, but more than depression. Any other underlying medical conditions like chronic pain syndrome, congestive heart failure, COPD, ongoing asthma disorders. Certain psychiatric conditions, including like MDP, like manic depressive disorder, in which when patients are very manic, they won't sleep at night. And when they are depressed, they are in bed all day long. Same thing with anxiety and depression, as we talked about the medications. And in female, as after menopause, the most common cause of insomnia, short-term and long-term both, is underlying obstructive sleep apnea. So in that phenomena, what happens is that patient stops breathing in sleep and they wake up at night, and their brain registers that it's time they are stopping breathing, so they wanna stay awake to stay alive, and it becomes a chronic habit and becomes causes insomnia. Very easy treatable, and when you fix the sleep apnea, insomnia improves remarkably. The most common symptoms of insomnia, both in the short term and the long term, is fatigue, irritability, malaise. They are sleepy, but they can't fall asleep in the daytime. So they're tired, exhausted, but they can't sleep in the daytime. Difficulty with concentration. You see a lot of irritability, a lot of intersocial or interpersonal behavior changes. You see a lot of mood disturbances, mostly anxiety, mostly irritability, and behavior changes. And they're also prone to very accident because of distractibility. They're very distracted, so they have very high chance of accidents. So the key feature of insomnia and the key approach to insomnia is how you take the history, find the important causes of the insomnia, and then manage accordingly. Now, before I go further, how many people in my group up till now who is attending the webinar have suffered insomnia, either acute or short? Okay, and if there's a short term, raise hands. There's long term. Okay, good. Yeah, we see that. I think, yeah, it's a very common. It's very common phenomenon. I would say 80% of the people in their lifetime either they suffer, at least have suffered a short term insomnia for whatever reason. So the approach is good history taking, very important. You need to exactly find out, because in the modern world, because of the short time we have with the patients and also the rush to see the patients, history taking is very important. Medications and those things are part of the treatment, but the history taking, understanding the underlying cause, is more important than treatment. Good history taking, what's happening, how long it's been happening, what has happened in last a week or 10 days before this, you had insomnia, you had a surgery, you had a divorce, or some death in the family, whatnot. Very important. Second thing, very important to get the sleep routine and sleep diary, just to know that what time they go to bed, what time they wake up, how many times they wake up, what they're doing in bed. Are they reading books, or they're watching TV, or they're using on FaceTime, and they're using the WhatsApp, or watching. Very, very important. Just to give you a perspective, last 1 year and a half, I've seen rise of insomnia incredible, very high rise in insomnia, and most of the common cause was because of their watching news and the pandemic. So very important that what they're doing, you need to understand that cutting those stressors can really help with the symptoms far more than giving medications. Now, the way I approach, and also the way the book says, that I approach the patient mostly with what is we call CBTI, cognitive behavior therapy. And in that, there are two most important parts. One is sleep hygiene, and the second thing is a main part of the CBTI is sleep restriction, stimulus control, and displacement. Actually, I have made this thing out of my own experience also. So sleep hygiene is a very common thing. You can also find on web, but the most thing which I recommend, most common things I recommend: wake up same time 7 days a week, go to bedroom only when you are tired, no TV, TikTok, Facebook, WhatsApp, half an hour before bedtime, no food or drink before bedtime, because some people who have GERD or acid reflux can wake up at night and cannot go back to sleep. Try to calm down before the bedtime, and then exercise every day, mostly in the morning time. Some people, when they exercise, the endorphin and the excitement goes up, so they normally they are unable to sleep. In some people, it will make them tired. If they makes you tired, exercise in the evening time. If they do not make you tired, do in the morning time. Very important. You need to do exercise in the morning time. So those things are like a part of sleep hygiene. Very important. Should be done even people who do not have insomnia should also follow the sleep hygiene pattern. Now, what I recommend in the CBTI the core treatment is that bedroom, not bed. Bedroom should be only for sleep and sex, nothing else. So no activity in that, not even book, no TV, no phone, no watch, no clock, nothing like that. That gives you a feeling that once you go in the bed, there's psychological or psychosomatic feeling that, oh, it's time for me to relax, and you go to bed. If you make your bedroom as a part of your living room or your activity, then the bedroom becomes living room, or bedroom becomes your office, and then everything gets messed up. So very important: sleep restriction, bedroom only for sleep. Stimulus control, so no TV, no media, no phone, nothing that can wake you up or gives you a dopamine boost or boost of kind of excitement inside the bed. And displacement. Displacement is whatever thoughts comes in your mind at the time of sleep, write on a piece of paper. For example, if you're worried about tomorrow's work, or have to have an appointment or go somewhere else, just write on a piece of paper. Very important. And nobody has to read that. Even bad thoughts, you can write it. So, and same thing you can do when you are sleeping. Suddenly you wake up and your mind starts racing. Just get up, go to the same place, and write on a piece of paper. And in the morning, you tear it up. You can even write, I want to kill that guy. I want to do this thing. I want to do whatever you need to work, whatever disturbs you, write. Initially, you'll see that you're going to write the whole thesis, a book. Then it becomes like a chapter, then a page, and then a few lines, and it becomes like normal. It works as good as medications. All the studies have shown that 80% of the time CBTI works, 80% times. And 80% of the time medication works. But CBTI is a long term. So it works for a long term. Medication works for a short term, and you need more and more of that as the time goes by. Now, what we achieve with CBTI. So the thing is that these things are major things which are addressed. So anxious behavior and thought about, sleeplessness, I'm going to die if I don't sleep, and that kind of thing, get rid of those kind of expectations about the hours of sleep time. Some people come to me, they say, hey, Dr. Das, I only sleep 6 hours and I feel horrible. So there's the normal sleep time is from 4 to 9 hours. Some people who are short sleepers, they can sleep 4 and they can still behave normally. Some people are long sleepers, they sleep 9 hours and they behave normally. So anything between 4 and 9 is normal. So nobody has to have expected 8 hours of sleep or 7 hours of sleep. That's a false notion. That's very important to understand. Like, okay, I only sleep 4 hours. I'm feeling fine, so I'm good. Like, all these big guys like Napoleon or, even Obama or Martha Stewart, and heard about Gandhi ji, they all slept 4 hours and they were equally functional and pretty highly functional people. And the other thing is tells you about relaxation. So we talked about the sleep restrictions and also meditation, mindfulness, writing thoughts on a piece of paper, breathing exercises also helps with the conservative measures. Okay. Now, the treatment, the medication part. These are the major categories of medication that we normally prescribe. Sometimes we prescribe together with CBTI. Sometimes I do CBTI for maybe 6 weeks and then I'll come back and then give the medications. So these are the categories. These are benzodiazepines, short-acting and long-acting, like diazepam, lorazepam, Ativan, those things. Non-benzodiazepines, like your Ambien, that Zalpidone, Sonata, that family. This is called DORA, dual orexin receptor antagonist. This is a new class of medication, fantastic. Only disadvantage, it takes a little bit of time to work and need to have a higher dosage of medication as the time goes by. Histamine receptor antagonists like doxepin, melatonin and melatonin agonists like Remeltion, and other medications like Cazodone and gabapentin. I'll talk about a little bit more as on the subsequent slides. So the benzodiazepines are the most common ones, and which I like to avoid. But the way it works is that it works on the normal inhibitory action of the GABA. There's a GABA complex in the brain that makes you sleepy. It works in enhancing the normal behavior of GABA, basically. The medications are, I just told you, diazepam, lorazepam. The longest half-life is diazepam and lorazepam. The other ones are, the shortest is triazolam. The advantage of this medication, it works very well, also cuts the anxiety. And also we give in patients who have anxiety. Bad thing, addictive. As the time goes by, you need more and more of the dosage. So I need to keep it as a second, third choice. But if push comes to shove or somebody has anxiety along with the insomnia, this is a good choice to give. Non-benzodiazepines are agonists. Basically, they are similar to benzodiazepine, but it works on the receptor instead of working on the whole mechanism. And the medications are zolpidem, that is Ambien, just short half-life. It is and we also give zolpidem XR, the long-acting one for sleep maintenance insomnia. The thing which you talked about, the DORA, dual orexin receptor antagonist, are a new class of medication. There is a hormone or receptor in the brain called orexin that really maintains our wakeful cycle. It antagonizes that wakeful cycle thing, so works against it. And it has shown to work very well, less side effect, and it is non-addictive. And there are 3 medications in that. Lemborexant, Survoxant, and this is brand new, just came out a couple of weeks ago. Daridorexant. It is the shortest half-life, so it doesn't give you hangover. And Lemborexant gives a little bit hangover. So basically, we give to patients who have to wake up early and go to work. Then the third choice is the better choice. The other common medication prescribed, which you have seen or you would have known if you have ever taken the medications, are doxepin. We also give for itching, but it is a highly sedative action, just almost like Benadryl, and it works very well. Remeltion, we give it to older people. It works on the melatonin receptor in the brain. Cazodone is the most commonly prescribed medication, and the mechanism is unknown. So, but it works, and there are few mechanisms which I wrote it on the receptors, but it is still unknown, but works, has less side effect. One of the bad side effects is priapism. It's like a uncontrolled erection, which could be fatal. That could happen. Other medications are SSRIs, like the antidepressant or anti-anxiety medications. And mirtazapine is also a very strong sedative. The only side effect is that it can cause you to have a significant weight gain, but it works very well. If somebody has increased anxiety and also has insomnia, mirtazapine could be a better choice too. Other medications are amitriptyline, that's a tricyclic antidepressant that we give it for patients who have difficulty with the somebody has neuropathy causing insomnia. You can give it in that case. Also, low dose like 25 milligrams can work very well for short-term insomnia. And then the SSRIs. Now, when you start to evaluate and want to evaluate the patient to get the medications, the patients who do not like benzodiazepines, for example, I don't want Dr. Dasi addictive, I've heard about that, I don't want to use that. In that case, we normally use the melatonin, the melatonin and agonists. Sometimes we can also give them mirtazapine, trazodone, over-the-counter Benadryl, although I'm not a big fan of Benadryl because it can cause confusion. People also have fallen. I've had a couple of patients in past that they took melatonin like a Benadryl or Tylenol PM, and they get kind of confused when they wake up at night and then they fall. So I'm not a big fan, but you can give that. Or you can also try the non-benzodiazepine medication like Ambien. Those medication can work. Dora can also work. But Dora is mostly for sleep maintenance insomnia, but that can work also sometimes. People who wants to try benzodiazepine, these are a list of the medication. Shortest acting is Trazolam. That's a good medication. Try to avoid that. These medications mostly in older people. Longest acting, I told you, flurazepam. Temazepam is also long acting, Restoril, but it works. It works. Only problem, addictive, and a little bit of side effect. And as the time goes by, people need more and more of the dosage. Other medications are like Lunesta and Ambien, so Zolpidem, Zolpidem. Those medications can also work well. People who have sleep maintenance insomnia, the most good medication are the Doras, which takes a little bit while to half an hour to work, but works throughout the night. Longer acting one like Sorvent, they have a little bit of hangover. So somebody has more hangover in the morning time. Try to give them short acting, short half-life, not short acting, short half-life medication like diazoxide, and it works well. Off-label, again, same thing, trazodone, mirtazapine, Benadryl, gabapentin, those medications work pretty well too. And again, same thing, same story about people who do not want to take benzodiazepines. Dora is a good choice. Low dose doxepin works. And then the gabapentin also works in a higher dosage, 300 milligram dosage works pretty well on that dosage. In certain case, special scenario is somebody who has a coexisting conditions like anxiety or manic depressive disorder. Try to treat the disorder first. So in anxiety, lorazepam, benzodiazepine, SSRIs works very well. Somebody who has an MDP or a manic depressive disorder, mood stabilizer like lithium and carbamazepine works pretty well too. And then try to avoid these medications in older people because of confusions and falls. And so now I'm going to take a short break. If you have any question, please write your questions in question and answer section. And towards the end of the talk, I'll try to answer your questions if you have any. And so I'm going to talk a little bit about how the Urgidoctor or a telemedicine can help in management of insomnia. So it can help in all aspects, in assessment, in CBTI management and initiation, and medication management and follow-up. A patient might need maybe one or two in-office visits, but rest can be managed on the telemedicine applications. You can ask questions, get the sleep diary, you can get the assessments done through the application. You can initiate the cognitive behavior therapy on telemedicine. Because they need a frequent follow-up. They need every 1 week, 2 weeks, 6 weeks follow-up to see how they are doing. That you can do on telemedicine. It will take you 5 to 10 minutes time for the patient and also for the doctor maximum. You can also see a psychotherapist who deals with insomnia through the telemedicine app. You can also, if you start somebody on medication, normally the way I do it is I see them after 2 weeks to see how they're doing based upon the side effects of the medication or the efficacy of the medication. So you can do that on the telemedicine app too. So this is the sample of few of the screenshot of my application which I made. So this is Urgidoctor application, and this is like doctors. You can make appointment with their physician. You can even do a visit now thing. You can choose the kind of physician you need to talk to. You can also get attached to your own primary care physician, and he can see you or he can follow you, or can find a psychotherapist or a psychiatrist on the application, and then try to follow up with the doctor. And then yeah, and if anybody wants to be a part of the Urgidoctor beta testing, this is the website. You can become part of it. It's almost done. We are doing the last tail end testing, and then I would like to get the feedback from you guys and see how I can make it better. So that's it for my thing. I looks like I have one question on the Q&A section, and I'm going to answer this. So this question is for Anupul. It says, with regards to sleep onset and sleep maintenance in problems, is there any specific cause that can cause either of these two separately or do patient concurrently? So as I discussed earlier, Anupul, that short-term insomnias are mostly less than 3 months old, and most of them have acute stressors. And most of the common thing which I see is that, in kids, we see like anxiety or exams issues, or in relationship issues, or could be death in the family or divorce in the family, or anything like that, which can be stressful on the mind. We see that. Chronic insomnias, this can also become chronic. If you don't treat the underlying cause, it can become chronic too. But usually, if you address properly with psychotherapy, with cognitive behavior therapy and medication, it does get better. It really gets better. So acute insomnia, very easy to treat. Chronic insomnia, a little bit difficult to treat, but does get better. And then, yeah, anybody else? Any questions? I hope I didn't rush it too fast, because I tried to finish the thing a little bit faster so that anybody can have any questions. Any personal question you can also ask. And also make sure that if anybody really needs to see me as a physician for this thing, when the app is out in first week of July, I will do a free consultation. Please let me know. There's a question from Preeti. The meditation or medication? It says meditation. Meditation should be done all the time. It's not should be done. Medication, once started, no. Usually, if you cognitive behavior therapy is done properly, we can stop the medication in 3 to 6 months time. Some people need for a longer period of time, but I normally in 6 months time I try to get them off the medications. And my biggest thing is that I see two kinds of patients in my practice. One is who really want medication, they love medications, and the other ones who really want to get better. So people who want to get better, the CBTI, behavior modification, sleep hygiene, really works. Trust me, really works. And then if once in a while there's a breakthrough, medication can be given, and I'm not against that. And there are many medications, as we discussed earlier. Now there's a question regarding, can you go over the sleep hygiene strategies? So these are, I'm going to say it again from the top, that will include both the sleep hygiene and some part of CBTI. First thing, get up same time 7 days in the morning, same time. Go to bedroom only when you are tired. If you're not tired, stay outside the bedroom, not in the bedroom, outside the bedroom. Bedroom sacrosanctum, only sleep. No TV, no phone, no watch, no alarm clock, nothing in the bed. If you want to wake up in the morning, put the alarm clock in the bathroom. For example, you went to bed and suddenly you can't go to sleep. Guess what? 20 minutes. Get up, go to a different room, do something boring. Boring doesn't mean watching TV or WhatsApp or Facebook. No, boring means knitting or reading a book or reading, National Geography, something like that. But do not start watching TV. Don't start washing dishes. Don't start cleaning house. Okay. Now, if for example, if your wake up time is 7 o'clock in the morning, and you could not go to bed till 5 o'clock in the morning, still wake up 7 o'clock, and no naps in the day. This is called sleep restriction. That's a part of CBTI. I still wake up 7 o'clock and no naps, because the way we sleep is the more awake you are, the more sleepier you become, and when the sun goes down, the melatonin goes up. There are only two ways you go to sleep: the higher melatonin level and more sleep pressure because of more awake you are. So no naps. Good. Now, half an hour before bedtime, write on a piece of paper whatever comes in your mind, and then destroy in the morning time. Same thing, if you're sleeping, suddenly you wake up, a mind starts racing, do the same thing. Write on a piece of paper, and then go to bed only when you're tired. No food or drinks 3 hours before bedtime. No alcohol before bedtime. If you drink alcohol, 1 drink 2 hours before bedtime, 2 drinks 4 hours before bedtime. The alcohol is a good sleep inducer, but it can also make you, it can cause a lot of sleep fragmentation. So no alcohol before bed. And never, never, ever use alcohol to sleep. Make sure. I see a lot of patients like that to drink alcohol to go to bed. Never. And exercise every day. Morning time is better because it keeps you more awake, and if that makes you tired, then do exercise at night time. That's fine with me too. No food or drinks. I told you about that. No smoking before bedtime, because that also irritates your upper airway and makes you more awake. Yeah, that's it. And if you have any underlying causes like ongoing anxiety or depression, that should be treated, because and that should be treated by psychotherapy and also by medication, because that really matters in your sleep management and insomnia management. Good. Anybody? Okay. Looks like there are no open questions. So thank you, everybody, for joining. I hope you learned something. Do not hesitate to call me. Most of you know me anyway. So call me if you have any questions, and we'll help you more than happy. If you want to become part of the beta testing, please do. And this is also used for multiple things. This is my app for consultation, doing pro bono help with the patients, adding your dependents, and you can do a lot of stuff. You can play with it and see how it is.